to make sure.
Yes, sure.
Okay. So, good evening, everyone. We're going to discuss today an interesting topic about the advanced echo modules in pediatric population. First of all, a small agenda about 3D echo, an introduction, indication of 3D echo in pediatric population, the techniques and modalities, application in pediatric cardiology, some challenges and limitations, case studies, and a conclusion. So, first of all, if you can see here this picture, we need always to see the other side of the picture to understand. So if you see here a small girl, a nice girl with that with a man, but when you see the other side of the picture, you can see that this girl is not a good girl. Okay, so we need to see all the sides of the picture to understand our studies, our echocardiographic studies. And that's why 3D echocardiography is very interesting. So why 3D echocardiography? 3D echocardiography help us to have a better understanding of the structures of the heart and the relation of various structures, okay? And it is easier to demonstrate to those who are echo-challenged and to have a better idea of all the anatomy of the heart, okay, and of the valves. And also, we can have a better representation of a realistic view of the heart valves, a better evaluation of the volumetric regurgitant lesions and shunts, and also the 3D echo Doppler, and even also some stress imaging with 3D echo. So, for example, here, the utility of 3D echo in mitral valve disease. We can see that the detection of mitral valve pathology with 2D and live 3D echo, we have a comparison here. We see that with 3D transesophageal, we have a better sensitivity and a better evaluation of the morphology of the valve. And also it is more comparable with the surgical finding we can see after. So some ideas about 3D echo. First, we use the fully sampled matrix array transducer. Okay, it is the development of a fully sampled matrix array transducer. It was developed in 2000, in the year 2000. Then currently, these transducers are composed of nearly 3,000 piezoelectric elements. And the single transducer can acquire both 2D and 3D studies. So here you can see the acquisition methods, okay? So the 2D, the normal frame per seconds. But with 3D, we can see several cardiac cycles, okay? We can use several cardiac cycles, and we can use also volumes, several volumes per seconds, okay? To have a better image resolution as temporal and spatial resolution, okay? So after these, we can find this type of images. So we have several modes in the 3D. We have the real-time or the live 3D images. Okay, so the real-time, we can use 3D while we are seeing all the images we have. Okay, we can have a live 3D with a narrow view. We can have live 3D with a zoomed view. We can have live 3D with a full volume of all the ventricle, and we can even have live 3D with a color Doppler. We can also have some imaging with several beats, with multiple beats, and some imaging with single beats. We're gonna explain this step by step, okay? So first, how do we choose our image? Okay, we use the narrow angle and the zoomed angle when we have valves, when we have interatrial septum issues, and when we have interventricular septum defects. And we use the multi-beat and the single beats when we are evaluating the left ventricle, the right ventricle, and the whole heart. And when we evaluate the volume, the ejection fraction of the ventricle. So here it is best to use the multi-beat or the single beat, okay? What is the difference and what is best between the multi-beats and the single beats? The multi-beats has a better advantage because we have a better images with higher temporal resolution. But the disadvantages in these cases, when we have patients with respiratory issues or patients with cardiac arrhythmias, we can't have a good image and we can't use the multiple beats images, okay? In these cases, the single beats is possible, but we will have a limited poor temporal resolution, okay? And we have what is called the multiplane mode, okay? What is the multiplane mode? So here we have, for example, a 4-chamber. We use the multiplane mode. We can see both the 4-chamber and the 2-chamber, okay? Here you have the mitral valve, for example, with the mitral clip. We can use here the multiplane mode. We can see both the 2-chamber and the 3-chamber on transesophageal echo. This one. So several views. Here, for example, we have the parasternal long axis. We can see the short axis. We can see here also, for example, from the parasternal long axis, the aorta, okay? So we can, with one view, we can see other views. That's the multiplane images. Now the real-time 3D we were talking about. First, the narrow sector. The narrow sector, this is a narrow sector. We emphasize on one single structure. Okay, for example, here it's the aorta. We can see the aorta. And we can see a single structure with a good image and a superior spatial and temporal resolution while we are using our probe. We have also the 3D zoom, focused and wide sector. You can see here, the mitral valve, okay, and we can see the other structures with the mitral valve. So that's why we have a wider sector. It's better for evaluation of the valves and the interatrial septum. And it is used when we go with cardiac interventions, okay? When we close an ASD or a VSD interventionally, it is a better view in these cases, okay? So here we can see we have an ASD, a small ASD. It's ostium secundum ASD. This is the 3D view. You can see the ASD and do a better measurement of the ASD, okay? So, and we have also the full volume. The full volume, as you can see here, we can see all the ventricle and the other structures. That's the full volume. Okay, we have a higher temporal resolution. We can have a better idea of the volume of the LV in these cases. And we can do what we call cropping. So when we save this image, we can do some cropping of the image after and have a better idea of each valve alone, the interatrial septum alone. We can do that offline, okay? After doing the echo for the patient. And also we talked about the multiple beat 3D echo. The multiple beat has a higher resolution. It gives us a better idea of the LV ejection fraction. But the only issue in these cases is when we have patients with cardiac arrhythmias or respiratory issues. We have a lot of artifacts, and these artifacts are called stitches artifact or stitching artifact. You can see here an example of the stitch artifact. You can see here the lines. We don't have a very good image. You can see here the small lines. Okay, so these artifacts are due to the patient, for example, has not has a lot of respiratory issues or has cardiac arrhythmia. We don't have a good optimal image to have a better image in 3D echo. Okay. So we were talking about the stitching artifact. You can see here also the artifact. Okay, same in case as we did say before, arrhythmia or respiratory difficulties. So we have a challenge between having optimal temporal resolution or having a spatial resolution, and the 3D echo can help us with giving us both a good temporal resolution with a good spatial resolution. But we always need a suboptimal 2D image will give us a suboptimal 3D image. So we always need a good 2D image to have the best 3D images. Okay. So it seems that some study demonstrated that with the 3D echo, the evaluation of congenital anomalies are compared to the anatomical specimen, but we have some issues in thickness, okay? And it seems that there is additional information gathered from 3D echo versus 2D echo in more than 36% of screened patients with a known congenital heart disease. So what are the indications for 3D echo in pediatric cardiology? First, the evaluation of complex congenital heart defects and unusual morphological variation, the evaluation of ventricular function and assessment of valvular function, and also in single ventricle patient, we can have a better evaluation of the ventricle, and also surgical and interventional planning, a pre-op planning, and during the procedure we can use 3D echo with transesophageal echo. Also, for example, when we are doing a closure of an ASD with an Amplatzer device or other things. Okay. So in addition,
I'm sorry for interrupting you, but
yes.
Can we have some examples of complex congenital heart disease that we can see better by 3D echo more than 2D echo?
An example? I didn't hear your question.
Any examples of complex congenital heart disease which we can assess by 3D echo better than 2D echo?
For example, you have the single ventricle. We can have a better evaluation of the volume of the LV function of a single ventricle using 3D echo more than the 2D echo. We can have also a better evaluation of the anatomy and the morphology of the valve in case you have a bicuspid valve with some association or other complex morphologies. In case of tetralogy of Fallot, for example, when you have atrial septal defects, several atrial septal defects, not only one, and this is not we can't see that with its unique 2D. We need a more advanced techniques to see if we have several defects and not only one. Okay, so I will give you some images after. And we can have a better even quantification of the cardiac shunts also. So as I was saying, 3D TE or 3D echo, it is better recommended when we have closure of selected ESD and VSD, multiple ESD, irregularly shaped. For example, if we have some residual defect, it will give us a better idea of the defects, okay? And also, in case of catheter interventions, here we have closure of an ASD, and this is an Amplitzer device. And you can see also the catheter while you are doing the procedure, okay? It is seen with 3D echo and transesophageal echo, of course, okay? And here you can see the ASD closure, the Amplitzer device. Also, as I was saying before, in cardiac malposition, it gives us a better idea of the complex of the spatial relationships of both the aorta and the ventricles, and both we have in case of transposition of great vessels, for example, okay. And as I was saying that the 3D volume, it could give us a better idea of the ejection fraction more than the M-mode or the Simpson evaluation of the volumes normally, and it is even used and validated in neonates and infants, okay? We have better images than in infants, so we can have a better 2D image, it's a better 3D image, but the issue in these cases that the children population has a higher heart rate and a smaller LV volume, and it could give us some potential sources of error in these cases. So this is, for example, an evaluation of the LV volume, okay? And here, even here, you can see the speckle tracking. We're gonna talk later about the speckle tracking. So in specific situation, for example, you have several ASD. These several ASD, we can see these several ASD on a normal 2D echo. Okay, it is here seen with 3D echo. So when we have, when you have several multiple defects, irregularly shaped defects, okay, and even residual defects, it has a good evaluation of these things. And also we can have an evaluation about an evaluation of the right heart, the right ventricle. The right ventricle is always a ventricle that is forgotten, okay? So even in the pediatric or even in the adult population, the right ventricle is always forgotten. So we have some special techniques to evaluate the volume, the ejection fraction of the right ventricle, if there is any RV dysfunction, if we can also do the strain of the RV to see if we have any longitudinal contraction issues in the LV, in the RV function. So also 3D could help us in these cases, and we can have a better evaluation of the complex architecture of the RV, and also the prominent trabeculation in these cases. So as we were saying about the volume, we can use it in functional single ventricle patient. This is one of my patient. It's a single ventricle patient with a tricuspid valve atresia, okay? And as you can see here, we have an evaluation of the ventricle. And it is same like using MRI for evaluation of the ejection fraction in these cases. And also evaluation of the valve. We can evaluate the size, the anatomy, the shape, and even the regurgitant orifice and the effective regurgitant orifice area in congenital heart disease. Here we can see, for example, a patient with prolapse. You can see here the prolapse and indicate where is the prolapse and which is it anterior, posterior, P1, P2, P3, to have a better evaluation of prolapse and the regurgitation, mitral regurgitation. But we have some challenges, of course, the equipment and the expertise, the patient cooperation, because these patients are young children or infant, they don't cooperate, and the limited temporal and spatial resolution of the 3D. So some take-home messages about 3D echo. We need a good 2D echo to have. If the patient is sick, don't bother to go and do 3D echo. You will not have good images and will not have any better idea than 2D echo. So what is the speckle tracking or the strain? Okay, the LV strain. What is the strain? The strain, it is equal to the deformation resulting from applied force. It could be a negative strain or a positive strain. It could be both. So strain, it is myocardial deformation imaging that offers a means to directly quantify the extent of myocardial contraction. We have several types of strain. It could be the radial strain that denote the thickness of the LV wall. It could be the circumferential strain with a reduction in the circumference of the LV cavity during the cardiac cycle. So the strain, it is the percentage change in the length of myocardial segment during a given period of time, and it has a unit of percentage. And there is something we call the strain rate, which is the rate at which shortening or lengthening is taking place per second. Okay, what is the time? Okay, it has a unit per second. So when we were saying we have several types of strain. We have the longitudinal strain, which is the most commonly used strain, the radial strain, which was the thickness here, and the circumferential strain. Okay, so the most commonly used is the longitudinal strain. It is used, for example, in patient on chemotherapy, to have an evaluation of their LV function after sessions of chemotherapy, to see if we need to stop chemotherapy in these cases when we have a decrease in the LV strain of these patients, even if the LV ejection fraction is good. So even in the pediatric population, who are on chemotherapy, we need to evaluate every 2 to 3 months after several chemotherapy sessions. We need to evaluate the longitudinal strain to have an idea about the longitudinal contraction of the LV. If we have a decrease in the longitudinal strain in these cases, we need to stop chemotherapy in several cases, okay, or change and use other chemotherapy. So if you look closely at the longitudinal strain, you can see that when the heart contracts in the longitudinal position, we have a shortening during the systole. That's why the number of the strain is always negative. So you can see, for example, strain equal -18. That's why, because the shortening of the ventricle is negative during systole, okay? So the evaluation of the longitudinal strain is always negative. So -18 is mostly the normal range. When we have less than -18, it means 14, 13, 12, minus 9, we have a decrease in the LV longitudinal contraction. Okay, when it is more, of course, it is normal, and we have several patterns in these cases. And the radial is positive, and the circumferential is negative, like the longitudinal. We use mostly the longitudinal strain, not the others. And the studies used in several cases are mostly on the longitudinal strain. Okay. So it helps us to provide an indirect estimation of the myocardial contraction function, but it does not measure it directly. Okay. And also, same as 3D echo. We need 2D good image to have a 3D good image. We need good 2D image for the strain to have a good and reliable values of the strain. If we have a suboptimal image of 2D, we can't do strain. So you can see here we have to use the 4-chamber view, the 2-chamber view, and the 3-chamber view. Okay, and we need to put points here to have so the machine will give us the evaluation of each wall alone. Okay, then you will have a summation of all these walls, and we will have this display, which is the bullseye plot. Okay, so this is a summation of all the strain we did. You can see here we have normal values, minus 25, minus, it is more than minus 18, okay? And we take the mean of the strain. They will display mean of the strain in the echo images. Okay, we don't have this here in this image. And the mean, it is the mostly used value to evaluate the strain. Okay. So what is the clinical application? We have some pattern recognition. For example, if in the middle we have the apex of the ventricle, if the apex of the ventricle is conserved and the other places of the ventricle and the other wall of the ventricle, we have an issue, what we call apical sparing. It means this patient has a pattern of amyloidosis, for example. Okay, so we have several patterns. And it also can give us an idea about some subclinical dysfunction and some regional variation. So, for example, this is one of my patients. Here is the 4-chamber. Here is the 2-chamber and the 3-chamber. So you put here your points, and the echo can give you the views of every strain for every chamber, then the summation with the bullseye here. Okay. In this case, this is a patient with ischemia. It's an adult patient. That's why we have these findings here. Okay, but I put this to give you an idea about the strain, how we do it. Okay. And are these 3D and strain images, are these only just some fancy pictures, or they give us some added value? So you need to decide about this. Okay, thank you.
Thank you, Dr. Randa. Thank you very much.
So do you have any questions?
Any questions?
Thank you for the lecture. Can I ask a question?
Yes, of course.
Do we use strain instead of regional wall motion?
You can have an idea about the regional wall motion when you do the strain. But normally, the eyeballing of the regional wall motion is better because you don't always have an optimal 2D image to have an optimal results of the strain.
Okay, thank you.
You're welcome.
So Dr. Randa, when do you use strain in conventional echo? In which patients?
Mainly, we use strain in patients who have some LV dysfunction. And we need to evaluate the LV function, ejection fraction, and everything. And mainly in patients with chemotherapy, as I was talking about chemotherapy patient for evaluation of dysfunction. You can use it in single ventricle patient to have an idea of the longitudinal contraction. In these cases, you can have a normal ejection fraction in these cases, but you can have a longitudinal contraction that is decreased. It means you have some microvascular issues. So we need to be aware of that after.
Okay, thank you.
You're welcome.
I want to ask a question about 3D echo. Can we use 3D echo in volume quantification instead of cardiac MRI?
If you have optimal images of 2D optimal images, you can use it. It is somehow similar to MRI.
I want to ask about the accuracy.
But still MRI is better.
And
but still MRI is better. It's somehow similar. But يعني the best is MRI, even if you have 3D echo.
Okay, thank you.
Oh, you're welcome.
طب في أي أسئلة تانية يا جماعة؟ Any other question?
I didn't. Yes.
Okay, thank you very much, Dr. Randa.
You're welcome.
Do we have another valuable lectures with us on Wikipedia, inshallah.